morning, everyone, and thank you very much for the kind invitation. It's always a pleasure and delight to be back here in Delhi and to be associated with Avatar. It's a good time to meet and catch up with colleagues and friends. Ethical issues in vascular access. I'm sure some of you have attended the workshop and heard me give this presentation. So this is the fourth or fifth time I'm giving the same presentation. So if you have heard this talk before, please excuse me. But I understand that this is part of the regulatory requirement as far as the Delhi Nephrology Association is concerned. So I have been tasked to give this presentation during this session. Ethics, again, let me just be clear that I am not an ethicist. I am a clinician, very much like all of you guys here, and I do face dilemmas during when I see my patients and the decisions that one has to take, decide between risk and benefit, decide between moral issues and legal issues, and these are issues that are situational based, regional based, and one definitely has to decide what's ethical in the given environment. Having said that, ethics is a broad topic, and not being an ethicist and a 10-minute talk, I'm going to touch on few principles, basic principles of ethics, and cover some of the values associated with ethics that we can implement in our practice. Ethics has often been misinterpreted with morality. Ethics has often been misinterpreted with legal issues, and overall, the way I look at it is medical ethics is trying to do the right thing while achieving the best possible outcome for every patient. And principles and theories in medical ethics apply to just about every problem or situation, and it's universal. You just have to figure out what's the best solution or best ethical solution in your given environment. The four basic principles on which medical ethics or ethical issues or ethical decisions are made are autonomy, beneficence, non-malfeasance, and justice. And I will touch briefly on all of these four principles, and the values addressed during the interactions between patients and providers essentially touch upon fairness, honesty, and respect. So when we talk of autonomy, it's the right to control. And here, the patient has the right to control and not you as a treating physician, even if the decision that the patient may take may be harmful from your perspective. And the patient can take this decision provided the patient is well informed. And once the patient has been well informed, so here's the operative word, informed patient. So a well-educated patient who needs to be aware of what's going to happen as far as the treatment plan is concerned. And then the patient has the right to choose or refuse a treatment. And once the patient chooses the treatment or refuses to follow with your treatment plan, it's our responsibility to respect that decision. It's not ethical to be paternalistic and impose your ideas or views onto the patient. And informed, while taking an informed consent, this autonomy becomes very relevant. The patient may not choose to undergo a procedure, which we may think may be relevant from our vascular access standpoint. And if the patient chooses not to undergo the treatment, we have to respect that decision. Beneficence and non-malfeasance. So beneficence essentially means benefit the patient. Non-malfeasance means do no harm. And together, it's striking a balance between what is going to benefit the patient and what is going to harm the patient. So one has to strike a balance between beneficence and non-malfeasance. And here again, in our practice with procedural nephrology, it's the question of, is the procedure really indicated? Is it safe to perform a procedure? Am I adequately trained to perform this procedure? And these are the questions that you should ask yourself and discuss this with the patient. On the other hand, justice is more of a societal or a healthcare policy or a healthcare advocacy principle, and it involves taking decisions regarding complex healthcare issues, especially allocation of resources when the resources are limited. And a classic example would be if there is a government funding or universal funding for dialysis, will the dialysis funding cover the cost of access care, and that's the kind of justice or the healthcare policy decision that needs to be taken at a much larger societal level, and these ethical values, if they are practiced, can be implemented and suggested as healthcare advocacy from professional societies to governmental bodies that take these decisions. And these principles are not new. The International Code of Medical Ethics was adopted way back in 1949, and there have been multiple amendments. The most recent amendment was in 2006. And these Code of Medical Ethics were laid down during the meeting of the World Medical Association. And these are essentially values that the doctors in general should implement in practice when interacting with the patients and also interacting with colleagues. The duties of doctors in general essentially are to focus on high professional standard and to avoid being influenced by motives and profits. As far as doctor-patient relationship, maintaining secrecy and complete loyalty to provide trust between doctor and patient relation, to maintain a trust between doctor and patients, and finally maintaining a collegial behavior between colleagues is something that is part of this International Code of Medical Ethics. So to highlight some of the points, what I thought was I would discuss some case studies, which probably will relevant to our practice with vascular access and nephrology or procedural nephrology. So here's a case study regarding informed consent. So you are showing your resident, the resident here is Dr. Divya Shah, who is about to place a tunneled central venous catheter for dialysis. How do you explain Divya's role and obtain consent from the patient? Should you introduce Divya by name and explain that she will be assisting you during the procedure? Option 2, should you introduce Divya as a physician in training? And option 3, explain that you will be closely supervising Divya, who is in residency training and is learning how to perform a procedure. So just a show of hands, who would choose A? Who would choose B? And who would choose C? So majority of you chose C, and I think the ethical answer is C. As physicians, as clinicians, we have an obligation to be honest and not mislead our patients about care. In addition, introducing the resident by name and explaining her role and general level of training, you should also tell the patient specifically that you're going to show Dr. Shah how to perform the procedure. And yes, you can always provide reassurance about the level of supervision that you will be providing and your confidence that this will not place the patient under any undue risk. So explaining this clearly is part of what we talk about ethics. And most patients will agree if they're approached in a forthright manner. If they choose not to agree, then yes, that's their right and that's the autonomy that they can implement. Case study 2, disclosing an adverse event. So Mr. Patel is undergoing a thrombectomy of a brachiocephalic fistula. While aspirating the anastomotic clot, a part of the thrombus gets embolized into the radial artery. Now, you were able to successfully perform an embolectomy procedure and reestablish the distal circulation without any sequelae. Mr. Patel is eventually transferred to the recovery room, and you are going to meet him and discuss the procedure, how it went in the recovery room, just before the patient is being discharged. So how would you tell Mr. Patel about this adverse event? Would you disclose the adverse event as it can still pose a risk in future? Would you disclose the event because clinical disclosure of adverse events is considered routine clinical care? Would you disclose the event because deliberately withholding information may undermine patients' trust? Or D, all of the above? So let's again see show of hands. Who will do A? Who will choose A? How about B? One hand. How about C? One hand. How about D? A lot of you. So yeah, the obvious choice is D, because as healthcare professionals, it's our moral duty to be truthful to our patients, and we have an obligation to act in patients' best interests. Clinical disclosures of adverse events should be a routine part of clinical care, And then doctor-patient relationships relies on trust and is threatened by deception and concealment of information. I'm running out of time. You think I can go over one case? I'm skipping one case. So case study 4 is performing procedures on newly deceased. And I found this interesting while reading about ethics, and I have done this in my early life, and that's why it was really very interesting for me to learn what actually literature says about performing procedures in newly deceased. So Mr. Singh has just passed away in the ICU. A PGY2 resident approaches you, you are the attending on the unit, for permission to perform a kidney biopsy before the deceased patient is moved to the mortuary. What would the right approach be here? Is it okay to perform the procedure as the biopsy needle leaves a very small puncture and it will go unnoticed? The trainee has to learn some time and better learn on a deceased person rather than a living person. C, obviously it's unethical practice and such practice should be avoided. And 4, options D is develop an institutional ethical policy that will allow training residents on newly deceased. So who would choose A? B, C, D? So everyone chose D. Yes, developing an institutional policy. So here, yes, performing procedures on newly deceased is relevant from training the next generation of physicians, but at the same time, we have to be mindful and respectful of the interests of all parties involved. The right of the deceased patient and the family, benefits to the training and to the society, and overall risks to the trainee, staff, institution, and profession. And these kind of policies or institutional policies can be developed and then implemented in the right manner, so that way the individual religious beliefs and individual cultural beliefs can be taken out of the equation. And finally, documenting these procedures in the medical records to keep it kosher so that everybody is above board and everybody is aware that some procedures like this are being performed. So the take-home message from my talk here is high-quality healthcare requires providers to be responsible in protecting the welfare of our patients. And as I mentioned, I briefly touched upon preserving professional behaviors, being truthful and trustworthy, treating patients respectfully, including the newly deceased, and avoid conflict of interest that may compromise objectivity. Thank you very much for your attention.